Hello.
Good morning, ladies and gentlemen.
Morning.
And we request that we just give it 5 minutes for a few more people to join in, and we will be starting soon. Just give us 5 minutes, and we should be starting. Thank you.
Good morning.
Good morning. Thank you. I think that we can actually start now. Good morning, ladies and gentlemen, and welcome to the COVID-19 monthly meetings that NHRA hosts. And we have these meetings every last Wednesday of the month at 10 hours. So we hope that more people will be joining us. And we are making a call to all the researchers that may have any research, any outputs, any results that from COVID-19 related work to reach out to us, and we can schedule them in to make a presentation. So before we go into our presentation, I would just like to welcome everyone and invite the Deputy Director from NHRA to give a few opening remarks, then we go straight to the presentation. Dr. Charlie.
Thank you, Ms. Mwango, and a big welcome to all our members and participants who have found time to join us for this monthly research dissemination meeting in relation to COVID-19. The National Health Research Authority has taken and further pushed its mandate to share or facilitate data sharing in research. And this is one of the platform where we try under this situation, the emergency situation of COVID-19, to share what is happening in the research space as regards COVID-19. And so we will be happy that we extend and expand this to most beyond the research institutions to the general Ministry of Health system, meaning that we want to see more participation by provincial health offices, by district health offices, and even facilities. And so I'll be encouraging colleagues, and NHRA will also use some initiative to make sure we bring on board a good representation from the provinces and the districts, so that there is reach, and also we provoke and push our colleagues at that level to participate in these important activities. This is an emergency situation. We still have a lot to learn. We've been, let me say, there is good picture coming up with information around the vaccine. Again, a lot more needs to be understood, and so requiring more research from the clinical side of vaccine to the social side of vaccine implementation. And so there is quite a lot to be learned, and participation of everyone, including those in facilities beyond the district and the provinces, is cardinal and important. And so let us, when we share information, extend these invitations to all, and we will try as NHRA to reach out and have more participants on this platform. So back to the topic of the day: implementation and evaluation of teleneurologic clinic serving vulnerable populations in Zambia during the COVID pandemic. I think this is another important topic and study that we will be happy to hear and learn more. How best our health system is responding during this pandemic. And so this is one area of interest to all of us. And so I ask for active participation from all of you, and we give the presenter, Dr. Sukile, the opportunity to share the findings. And so welcome to all the participants, and welcome to our presenter, and thanks for all your hard work that has been put into this to put this paper together and make this presentation possible today. So thanks, and we can proceed with the presentation.
Thank you so much, Dr. Charlo. Just before the presenter comes, would like to request that you introduce yourself. We're happy that you're on video so that we can feel like we are communicating in person and you're not speaking to the computer. I also realized I didn't introduce myself, but my name is on the program. My name is Kota Banda Mhango. I will be facilitating this meeting. To the participants, if we have any questions, any comments, that would like to make, let's utilize the chat box. And we also request you to just introduce yourself in the chat, give us your name, your affiliation, and we can move from there. Thank you so much. Dr. Sukeli, you should be able to share your screen. Thank you very much.
Thank you, Madam Mhango, and sorry I didn't switch on the video when I was giving the opening remarks, but I'm sure a number of people might know me, but I'm Dr. Victor Charlo, an associate professor in health sciences and deputy director at the National Health Research Authority. Thank you.
Thank you very much, Dr. Charlo and Ms. Kuta. Yes, so I'm Dr. Asukile. I'm one of the neurologists at the University Teaching Hospital. And so I'm just going to share our study that we did, I think, which is quite relevant during the COVID-19 pandemic. And so the title of our study has been alluded to, is Implementation and Evaluation of a Teleneurology Clinic Serving Vulnerable Populations in Zambia during the COVID-19 pandemic. So as a background, telemedicine increased during the COVID-19 pandemic as a safe and feasible alternative to in-person care. Though it was noted that this expansion was primarily limited to high-income countries, but it was likely that it could benefit low-income countries as well. So Zambia has about 18 million people, but we only have 8 neurologists, 4 recently qualified Zambian neurologists and 4 expatriates. And we only have 1 outpatient neurology clinic, which has long waiting times for clinic appointments and long first come, first served queues. So as such, a telemedicine intervention could have potential benefits for our setting. During the peak of the COVID-19 pandemic, outpatient clinics at UTH were temporarily suspended. And so there was urgent need for alternative methods of continuing neurology outpatient care. And this is how we came up with a telemedicine solution and implemented it. So the objective of our study was to evaluate patient and physician acceptance of and satisfaction with teleneurology visits for adults usually attending in-person visits at the UTH Neurology Clinic here in Lusaka. For our methods, all patients who were scheduled for a neurology outpatient appointment in June and July of 2020, and those with missed appointments between March and May 2020, were called to ask if agreeable to a televisit. For those who were agreeable, neurologists conducted teleneurology visits over the phone, WhatsApp video, or Zoom calls based on whatever was available to the patient. Following the visits, neurologists would complete Google Forms documenting visit outcomes. And then further on, we got patient and provider satisfaction through telephone surveys for patients and online surveys for the physicians. And so I'm going to present the descriptive statistics of those results. And so for the baseline characteristics, we called about 300 patients, and about 62% of those were reachable. Of those 186, we managed to get 133 who agreed to a televisit. And so these are of those who are alive, because some of the patients had demised from the patients that we were able to contact. And so this table just shows some of the characteristics of the patients. So those who refused the televisit were 46, 133 who accepted. And these are the ones who then did the satisfaction survey later on. And so they had similar age ranges in their 40s and just about half were male, though we have slightly more males in the post-televisit survey. For the patient diagnoses seen during the televisit, so it was noticed both for those who refused and accepted televisits that stroke was the commonest diagnosis, which essentially reflects what we see in our clinic. The largest proportion of patients we see are stroke patients. We noticed that for those who accepted televisits, stroke, seizures, and headaches were the most common diagnoses that we saw. In the refused televisit, it was an interesting note that those who had dementia and those who had neuropathy tended to refuse a televisit. And this could be because of the challenges of examining and interviewing a patient with dementia over the phone, and similarly with the need for an examination for a patient with neuropathy. So with regards to the modes of contact, majority of our patients, 80%, were contacted through a telephone call, 14% through a WhatsApp video call, and 6% through a Zoom call. Technical quality was comparable in all three modes of contact, but we did note that confidence in assessment was highest for those who were seen using a Zoom video call, though assessment was comparatively acceptable even for telephone and video call. So the rate was from 1 to 5, with 5 being excellent and 1 being poor. And so they all have a rate of about 4, with almost 5 for a Zoom video call. So reasons for visit preference. We asked patients why they would prefer a televisit over an in-person visit, or why they would prefer an in-person visit over a televisit. And so some of the main reasons that patients preferred televisits was because they thought they were less expensive, they thought less time was involved, and they also thought that it provided more privacy. When asked about why they preferred in-person visits, it was thought the main reason for in-person visits was because a televisit did not provide for a physical examination, and so majority would prefer an in-person visit for that reason. When we look at the satisfaction with televisits, we asked both the neurologists and the patients about their satisfaction. There were 7 neurologists who responded to the survey out of 9 eligible. So these neurologists include both the qualified neurologists and our neurology residents. And then the patients are the ones who we managed to contact about 3 months later after their visit to get their satisfaction. And so the lighter green shades on this graph show extreme satisfaction and somewhat satisfied, as you can see from the key below. And then the darker green are those who would be extremely dissatisfied or somewhat dissatisfied. And so what we can see from this chart is that both neurologists and patients were overall satisfied with the televisits, and they had similar satisfaction in terms of the quality of the video and the audio. What was interesting is when we asked about perception of comfort and privacy, physicians actually had mixed feelings about how they perceived the patient's comfort. But when the patients responded to the survey themselves, a majority of them actually said they felt very comfortable and they were very comfortable with the privacy. And so what are some of the outcomes of our televisits? So these are percentages of patients that were seen. And what we noted is that of all the patients that we saw, up to 30%, just from the televisit alone, we could assess that they were stable, and they were discharged from the neurology specialist clinic to follow up at their local clinic or first level hospital. About 32% of patients were also stable. They needed no changes in their medication, but needed to get refills for their medication. And so what we did for these patients is we would write prescriptions for them, leave them at Clinic 4, and they could pick them at their own convenience and collect their medication at a time convenient for them, which again supported the social distancing. 19% of the patients we saw, however, were deemed to need an in-person visit to complete their assessment. When we asked the neurologists which conditions they thought were most amenable to televisits, the most common was the thought of follow-up visits for stable patients. So patients who are known to the clinic, who are stable, those can actually be followed up using a televisit instead of an in-person visit. Again, stroke was thought to be another condition that we could evaluate through televisit, and less commonly was headache, epilepsy, and new patients with Zoom visit capabilities. Some of the conditions that were thought not to be amenable to televisits were things like neuropathy, dementia, and myelopathy, which are spinal cord syndromes, and which are things that usually require a physical examination for a complete assessment. And so in conclusion, teleneurology visits were an acceptable means of service provision for adults attending the ETH Neurology Clinic during the COVID-19 pandemic. We think they're a promising supplement to in-person visits in resource-limited settings, even when video call support is absent. And we recommend considering continuation of teleneurology visits for selected patients, even beyond the COVID-19 pandemic. Thank you.
Thank you so much, Dr. Sukile, for that presentation. That is indeed quite insightful. And I see that we do not have any comments or questions in the chat. So at this point, I would like to invite any comments, any questions, any feedback that we may have. Please just unmute your mic and go ahead if you have any submission. I know a number of people joined in the middle of the presentation, but I hope that they were able to get the presentation at least at the end. Do we have any submission? Yes, I can see Dr.
Yes,
Mangela.
Yes, thanks. Thanks for the presentation. Interesting. I wanted to find out if the patients were provided with the means to access the teleconsults. Those who didn't have phones, were people given data bundles? Just a bit more clarification there.
Okay, thanks for the question. Yes, so the first thing is this was a reaction, really. So we were in a state where the clinics were canceled, patients were not coming. And so we came up, we thought, what's the best way that we can access patients? So we phoned patients. So we were the ones using our talk time to speak to the patient. But when it came to WhatsApp video or Zoom calls, that was if the patient had it available. So if the patient said they had access to data, or if the patient had a laptop, access to Wi-Fi, then those patients, we would see them. But we didn't provide any monetary support for the patients. The only thing is we did call them from our funds, our own talk time, but for those for WhatsApp and Zoom, they provided their own resources.
Thank you.
Thank you. I see a hand from Tisa. Please go ahead.
Yeah, thank you so much for the presentation. I had a very quick question on a discrepancy that you might have highlighted. You said the clinicians felt that the patients were not so comfortable during the sessions, but the patients themselves said they were very comfortable. And I'm wondering why there was that discrepancy. Was there any further investigations that you did to also figure out maybe the quality of data that clinicians were getting throughout this particular process, and why, you know, there may have been that distinct difference between the receiver and the giver of the information?
Okay, thank you for that question. So this question, it was a survey question. We asked the physicians how they perceived. So if they were speaking to the patient on the phone, or they saw them on a video call, did they feel the patient was comfortable? Did they feel the patient had adequate privacy? So the physician may have perceived that as not. So for example, maybe in their interaction with the patient, they may have felt, if I saw this patient in person, that we could have interacted a bit better. But for the patient themselves, they reported that they were comfortable. So it's difficult to really say what the reason is, because it's a matter of perception, but it also speaks to, there are many times as a doctor, you perceive something of a patient. You might think a patient is not happy, a patient is not comfortable, but when you ask them, they're actually comfortable. So these are personal perceptions that we didn't go into much detail to interrogate, but I think it just speaks to how what we providers may perceive as one thing, patients might perceive as another, I think.
Thank you for that response. There's a question in the chat, Professor Yusuf. Professor Ahmed asked, how do we manage documentation? And also Dr. Mwangela added to that, saying, in addition to that question on documentation, what documentation did the patients discharged to local clinics go with?
Thank you. That is a very important question, and that's actually something that was a challenge. So in many of these patients, as you can imagine, we were phoning them and we didn't have their records with us. And so a lot of times we had to depend on the patients who got files at their homes. So there were those patients, many patients do carry their files at home. So those patients who have their files at home, we would ask them to check what's in the file or to send us a picture of their last appointment. And then after every visit, we would actually write notes. So usually we would document notes either on a paper or electronically. And so if a patient is being discharged, we would write them a discharge letter, which we would ask them to come and collect from Clinic 4. Or if able, we would send it as an email or send it on WhatsApp and ask them to then send that to take that to their clinics as a discharge letter. For patients who are going to come back for further reviews, all the notes that we had written would be with the clerks so that when they come for their next appointment, the note of that visit would be attached to their file. But that said, I mean, it wasn't a perfect system. And there are those gaps that we notice as ourselves, and also just the record system is quite challenging still here at UTH. So we still face those challenges, but those were some of the ways that we tried to get around it.
Okay. Do we have any further feedback? Are we okay with the responses? Do we have any follow-up? Okay.
I see there is a question. Do we have telehealth units for follow-up of all COVID-19 positive cases in each province? All right, so I mean, for our study, it wasn't necessarily looking at COVID-19 patients. We were looking at the neurology patients who come to our clinic. So I'm not sure if there's anyone else maybe on the forum who might be able to respond with regards to follow-up of COVID-19 patients.
Okay. Thank you so much, Dr. Sukeli, for that. We do have a hand. Chris, please go ahead.
Yeah, thank you very much for the interesting presentation. So I have two questions. So the first question is how I want to find out how you dealt with the courtesy bias, because you have patients and the you get a healthcare worker to call a patient, and then you ask the patient whether they are satisfied with, I don't know if it's the call or the service. I think in research, you are more likely to get patients telling you that they are satisfied. And that is courtesy bias. They are more likely, you've called them using your talk time and you are a healthcare worker, there's that level of power. So patients will most likely tell you that they're satisfied. So how did you deal with that bias? Then the other clarification, I just want to find out, when you asked them whether they were satisfied, was it satisfaction of the service that they got from the people that called them, or satisfaction of the call, like the call was clear and the network was good or something? So that is not very clear when how you measure satisfaction. Thank you.
Thank you very much for those two very important questions. So the first one, the courtesy bias, I think that's a very valid point. So the way we tried to alleviate it, though might not be complete, is that the televisits happened during June and July. And then about a month later, we got a nurse, so someone who wasn't involved with the clinics, is the one who then made the phone calls to find out about satisfaction. So she would call and explain that she's not related to the doctors, she's not working with the doctors, but she's calling to find out, to follow up if they're satisfied with the visit or not. The fact, as you've said, though, that she is equally a health worker, she works at UTH, could have created some bias, but we tried to alleviate it by avoiding the doctors themselves asking the patients about satisfaction. With the other, I hope that's okay. So I mean, essentially we didn't completely exclude bias, but that's how we tried to do it to some extent. The other question, I'll just refer to this slide. So we asked several questions about satisfaction. So we asked about overall satisfaction with the televisit. So the overall experience, how did they perceive it? Then we asked about satisfaction with the quality of video during the televisit for those who had video calls. We asked about satisfaction with the quality of audio during televisits. So for those who had audio. And then we asked about satisfaction with comfort and privacy of the patient during the televisit. So there were several different aspects of satisfaction that we asked, and these were the responses based on those. These are actually percentages. So to note that some, for example, video, not everyone had access to video, but this was satisfaction. So about half were extremely satisfied, another half were somewhat satisfied, and with a very few percentage were dissatisfied. So that's how we broke down satisfaction.
Thank you for those responses. I see Dr. Mwinga's mic is unmuted. Would you like to contribute something, Doc?
Yeah, thank you very much.
How are you?
I joined a little late, but I appreciate the presentation and think there's a lot that could be learned for other areas. So just thank you for the work.
Oh, thank you very much for that comment.
Okay, I also now would like to just ask Professor Ahmed. He's written something in the chat, but I thought I could ask him to just speak to that one or two things. Prof. Ahmed, are you able to speak to us? And if you're
Yes.
able to show your video, if possible, that would be great.
My hair is not combed properly, so I'll stay.
All right,
I think this is great, Dr. Asukile, great presentation, and I think good initiative. I think in these times, I can tell you many other countries have very rapidly gone on to telehealth, and there's absolutely no reason why we shouldn't either. I did mention documentation, and obviously there are limitations to telemedicine. We cannot do physical examination, for example. And you know, so there are times when that is quite critical. But for some of the other processes, for example, follow-up, we want to get an idea of how symptomatology has evolved or whatever. I think this is a good way. I think you can reach more people. I did make a comment on this smart care issue. We are giving smart care cards to as many patients as possible. The issue is that the smart care readers or writers, as they are, might not be available in every center, despite quite a huge investment. But as proof of concept, this is the sort of thing that can be done whereby for purposes of documentation, you can say visit has been documented in the system, right? Because you can get permission from SmartCare to access, not even having the physical card with you, but you know the ID and all that. You can log on and get that person's documentation on your screen, write what you need to. Next time the patient goes to a SmartCare facility and they put their card into the reader, whatever's in the server would get uploaded. So I think my only comment is that we need more proofs of concept like you have just shown. I have heard some of the critique as well, but I think we should continue with this. There are some patients, some selected patients where this would be a very good idea for. And I know some of the other countries, like for example, the obstetricians and gynecologists in UK, USA, of which I'm fellows, they have had this right from the onset of COVID in selected patients, in selected conditions, under very strict HIPAA conditions where documentation doesn't go awry, and so on and so forth. The big problem, as I stated right earlier, is the inability to do physical examination. But otherwise, telemedicine should certainly become entrenched in our system. Thank you very much once again.
Thank you, Professor Ahmed. I think we can take in one more comment or question. There's actually something in the chat from Victor Boa, who says, thank you, Dr. Sukile, for the good presentation. How did you take care of patients in need of medication and physiotherapy, as well as data bundles for the patients who could not afford to buy bundles for this important interaction with the neurologist?
Thank you very much for those important questions. So starting with the medication, we had several types of patients. So there were those patients who just needed to continue their current medication. Then there were those patients who needed a change in their prescription. So essentially what we would do is we would write out a prescription for the patient and leave it with the clerks in Clinic 4. And then the patients could either come or they could send a relative to come and collect the medication on their behalf. For some patients who were out of town, we would actually write the prescription out electronically with a letter attached, which they could then take to their local clinic or hospital to show that the doctor prescribed these medications for me. And then they would collect those medications based on that electronic printout at their local hospital. But most commonly, patients would come and collect the prescription at a time convenient to them. So with physiotherapy, it's similar to the discharge letters we were writing. So if we deem someone needed physiotherapy, we would write them a letter again of referral to physiotherapy, which they would either come and collect at UTH or we would send to them electronically, and they would present to their nearest first level hospital. I think we already touched a bit on the data bundles. I mentioned that this wasn't a funded study, and it was really an initiative that we took to try and contact patients. So most patients, as you saw, 80%, we spoke to them just on telephone call alone. And many of the patients that we saw, though I didn't show in the presentation, were review patients. So these were patients we already knew before. Those who did have access to WhatsApp and who had access to Zoom calls, and if they had bundles, then we would use that means of communication, but we didn't have any financial assistance to provide to the patient.
Thank you so much for those responses, Dr. Sukile, and for the time. I know there's still a few discussions going on in the chats, and these are very helpful. I lost connection for a bit, so I may have missed one or two things. But I think this has been very informative, and as Dr. Mwinga said, I think that this telemedicine is a way to go, and it's something that we need to consider and look into more for the different service points. At this point, unless there are some burning questions or comments, I would like to just call again Dr. Chale if he has one or two things to say, as we end the meeting. Dr. Charlie? Okay. I'm not sure if Dr. Chalwe is still there. I know he had 2 meetings at the same time. So I think that from our end as NHRA, just to communicate that we are happy to provide a platform for researchers, for anyone who has any evidence to share. We have the COVID meetings held monthly, that is every last Wednesday of the month at 10 hours like this. Today, we only had 1 presentation. So ideally these meetings take about an hour, but we had 1 presentation. And so we finished a bit early. And we also have quarterly scientific or research meetings. These are held every quarter. So these are held in the last month of the quarter. And I think we've sent out some communications to that effect. We would like to take this time to thank everyone that has participated in this meeting. And we would look forward to having you in the forthcoming meetings. Please feel free to reach out to us if you have any information that you would like to disseminate, and we'll create that platform. Dr. Asukile, thank you so much for taking the time to make this presentation. I'm sure that this is going to inform a lot of people, a lot of programs, and we will carry this forward. Thank you so much for everyone for joining. And this presentation, the abstract of this is going to be on the NHRA website. Please visit the website and you can access it. Have a good day and thank you again.
Thank you. Bye.
Thank you.
Bye.